topic we are going to discuss here is applied physiology and mechanistic principles of invasive ventilation. And already yesterday, Dr. Suti discussed this, that NIV is a process of supporting respiration using devices that do not require an artificial invasive airway like endotracheal intubation or tracheostomy tube or supraglottic airway device. And the primary desired effect of NIV is to maintain the gas exchange, maintaining adequate oxygen level and CO2 level in the arterial blood, along with unloading the inspiratory muscles. So just for a quick recapitulation of our physiology on respiratory mechanics, it is all related to pressures and the pressure gradients. And we know for a gas to flow from our air through the airway, pressure gradient must exist. And that pressure gradient is starting from the mouth till alveoli. So it is pressure at mouth is, I'm labeling it as airway opening pressure, then alveolar pressure, and these are important in describing the gas flow. Second is intrapleural pressure and body surface pressure or atmospheric pressure. Also, in some patients with where we are expecting there is increased intra-abdominal pressure or abdominal pressure, intra-abdominal hypertension, we have to take intra-abdominal pressure also into this calculation, which affects the pleural pressure change on diaphragm movement. So this pleural pressure is the pressure in the pleural space and is usually negative in relation to alveolar pressure. So the respiratory system is everything that exists between airway opening and the body surface. And the associated pressure difference is trans-respiratory pressure, which is defined as airway opening pressure minus the body surface pressure. And the airways are represented by trans-airway pressure, which is airway opening pressure minus the alveolar pressure, which will define the gas flow from the nostril to the alveoli. The lungs represented by transalveolar pressure, and transalveolar pressure is alveolar pressure minus the pleural pressure. So the chest wall is the trans chest wall pressure. When we have a rigid chest wall, any burn patient, in these situations, chest wall pressure also plays important role. So if the lung and chest wall are lumped together, they can be represented as transthoracic pressure, and which is alveolar pressure minus the body surface pressure. Now, in spontaneously breathing patient, how it is going to affect the intrathoracic pressures. So in spontaneously breathing patients, it is an autonomic phenomena, and we do not think about breathing. It is controlled by the autonomic nervous system. So not until our breathing is stressed, we don't get that effort to breathe or any energy is expended. We don't feel like that. So at the end of exhalation, what happens is intrapleural pressure is slightly negative. Alveolar, mouth and body surface pressures are zero because there is no airflow. The diaphragm contracts in response to stimulation of the phrenic nerve via the respiratory center in the medulla. And when the diaphragm contracts, it descends the abdominal cavity, and which causes negative intrapleural pressure. So when intrapleural pressure becomes more negative, alveolar pressure also becomes negative. And under normal circumstances, decrease in the intrapleural pressure results in decreased alveolar pressure, and it increases the trans airway pressure, and which causes the air to flow from the mouth to alveoli. What happens when there is positive pressure ventilation? So in positive pressure ventilation, it causes air to flow from the lungs because of the increase or positive pressure, not because of the negative pleural pressure. And it is similar to spontaneously breathing patient because the air is flowing definitely from the airway opening to alveoli. But positive pressure ventilation causes an increase in the transpulmonary pressure, which allows gas to flow into the lungs. And gas flows into the lungs because pressure at the airway opening is positive. Unlike it is negative intrapleural pressure, which is causing the pressure gradient in spontaneously breathing patients. And the alveolar pressure is initially 0 or less positive. So alveolar pressure rapidly increases during the inspiratory phase of positive pressure ventilation. And the increased alveolar pressure, it expands the airways and the alveoli. Now, because alveolar pressure is more than the pleural pressure during positive pressure ventilation, so this positive pressure is transmitted from the alveoli to the pleural space, causing the pleural pressure to increase during inspiration. And depending on the compliance and resistance of the lungs, pleural pressure may markedly exceed the atmospheric pressure during a portion of inspiration. And these changes in the pleural pressure during positive pressure ventilation can lead to significant physiologic changes that we are going to discuss next. So this pressure, because we know that through all the alveoli, the blood vessels, capillaries are crossing. So this causes the changes in the hemodynamics also. Pressure gradients during positive pressure ventilation are similar to pressure gradients during spontaneous breathing, except that it is created by the positive pressure at the airway opening, not like spontaneously breathing, as I discussed, negative pressure in the pleural space. So all pressure gradients change in the same direction as during spontaneous breathing, except trans-respiratory pressure change, which is in the opposite direction. So this is how it is happening. So during inspiration on the left side, expiration on the right side. So this is 0, and when the positive pressure starts in positive pressure ventilation, at the opening it is positive. So alveoli, it is going positive. Pleura, slight positive. But because there is more positive at the opening, less positive at the alveoli and the intrapleural, so that's why pressure gradient is there and air is flowing, gas is flowing from the airway opening to the alveoli. And then inspiration, it is going to be passive. So this is volume, inspiration, it is going up. Then expiration, airflow, it is decelerating pattern of airflow, and then it is expirating by the expiratory flow. Now, this small just mention about the NIV versus invasive ventilation, because this way we can say that why we are not using NIV in all the patients, why we are concerned about the invasive ventilation also. So there are few problems which we can face if patient is on NIV. There can be leak which can affect the patient's minute ventilation and with affect the synchrony also with the ventilator, because there is positive pressure ventilation, the lower esophageal sphincter, it gets open, so there can be aerophagia and gastric distension. There is a risk of aspiration also, because gastric distension and open with the pressure opening of the lower esophageal sphincter. So if the stomach is full and patient is not fully conscious, then it can cause aspiration. There can be rebreathing depending on the interface and the types of non-invasive ventilation used. The second is the specific physiologic effects of NIV that we are going to discuss next is on both respiratory system as well as on non-respiratory system, including the neurologic and the cardiovascular system. And that we have reviewed here. So on respiratory system, starting with the augmentation of the minute ventilation. So we all know that when we are using NIV, our main aim is to improve the gas exchange. So with the positive pressure ventilation, the tidal volume is increasing. It can be the controlled machine time triggered or augmented during assisted like patient effort triggered breaths. Either way, the minute ventilation delivered to the patient can be increased substantially depending on how much pressure or how much positive pressure we are applying. So this is going to increase the alveolar ventilation. Now this is going to increase the minute ventilation. Now our alveolar ventilation is minute ventilation minus the dead space. So dead space comes, which is the part of the gas which is not taking part in the gaseous exchange with the blood. So that is the dead space volume. So this alveolar ventilation will be minute ventilation minus the dead space. Now, these are the two equations. So this is PaO2, partial pressure of oxygen in the alveoli. This is PiO2, that is the inspired oxygen, and VO2 is total body oxygen consumption. VA is the alveolar ventilation, K is the constant. So in this equation, we can see that PaO2 is directly proportional to alveolar ventilation, because if you will calculate, this is in denominator. So this part, if it is high, VA is high, so this bracket, this part will be on the lower side. So this PaO2 will increase. Second is PaCO2. It is inversely proportional to minute ventilation. So VCO2 is total body CO2 production. This is alveolar ventilation and this is constant. So if minute ventilation is high, then your PaCO2 will be on the lower side. So the ultimate, this we saw how this minute ventilation is affecting the partial pressure of oxygen and the CO2 in the pulmonary venous blood. But the important is the gas exchange also matters, because this partial pressure of oxygen and the CO2 is in the alveoli, but our ventilation and blood. So ultimately, PO2 and PCO2 in pulmonary venous blood entering the left atrium depends not only on the minute ventilation, but also on the ventilation perfusion matching. So that is the VQ matching relationships, because if there is a portion of the lung which is well ventilated, but it is not well perfused, so that part will come under dead space, because that is not taking contribution, that is not contributing into the gas exchange. If there is a part of the lung which is not getting ventilated, suppose there's a consolidation or there is atelectasis, that is not taking part into the ventilation, but the blood is flowing through it, then again that is perfusion is happening, but ventilation is not happening. So ventilation perfusion matching is important for the gas exchange. So here we can see these are the lung capillaries. This is collapsed alveoli. Okay, so you can see the surface area. In case of collapsed alveoli, you can see the surface area. So this part will take in the very lesser area will take part in the gas exchange. When we are giving the positive pressure ventilation, so this part is opening up and getting ventilated, open, and will participate in the gas exchange better, and that will improve the oxygenation. Second is NIV unloads the ventilatory muscle. So this total pressure is required to overcome two main pressure resistance in the lung. That is, first is respiratory system elastic recoil, and second is airway resistance for a given flow and the volume exchange. So this P total is P elastic plus P resistance, and that is affected by the lung compliance. So P total is equal to delta V, that is change in the volume, divided by the elastic lung compliance, plus airway resistance into the volume. So this is also with the NIV, we are able to overcome this resistance, P total resistance. So in that way, it is improving the lung compliance. So this is a very good picture that I got from internet. So it is the x-axis is showing the pressure, y-axis it is showing the volume, and this diagonal line, that is showing the passive respiratory system compliance. So pressure on the left, this area on the left side, it is the patient generated pressures, and on the right side it is the machine generated pressures. So the area under this curve is the work of breathing. Now we can see in this picture A, it represents a normal subject with normal work of breathing. In picture B, so it is this area under the curve is high. This is more we will see in obstructive airway disease, where the work of breathing is high. Again, this C, it represents totally machine unloaded lung with the machine breaths delivered to the patient and no patient work. This D is representing patient only doing enough work to trigger the breath. This one, this is just triggering the breath, but otherwise most of the work is being done by the machine. This E, it represents that patient is generating, triggering the breath, making an effort, but it is assisted by the ventilator. And F, it is showing this, that is there is a ventilator patient dysynchrony, and that will cause excessive loading of the patient. So whenever patient is on positive pressure ventilation, we should try to stick to E pattern so that patient is generating the trigger with good coordination with the ventilator, and it is allowed, the patient's breathing respiratory muscles are allowed to work also. Now, third is NIV resets the ventilator control system. This is very important because we all know that our ventilator control system, it is present intrinsic pattern. It is in the brainstem, and it has intrinsic pattern generator with important inputs from the oxygen, pH, and also from the stretch receptors presence in the thoracic cavity. So the output from the ventilator control system controls the ventilatory muscle, inspiratory muscle intensity and timing. So if patient is acidotic or patient is hypoxic, so this brainstem gets stimulated because there is a chemoreceptor presence and it gets stimulated, and then patient becomes tachypneic, or it starts generating more negative pressure for air hunger, because of air hunger. So when we are, you will see this flow chart, just try to understand. If we are giving NIV, so NIV improves the gas exchange. It will improve oxygenation. It will improve pH by improving the CO2 washout removal also. And then it affects the intensity and the intrinsic pattern generated in the brainstem. Also, NIV improves the respiratory muscle load, and it will act on the stretch receptors, and it unloads the muscle. Again, this will affect the intrinsic pattern generated in the brainstem, and that pattern will regularize the breathing more towards the normal side, because now stimulus is getting on the normal side. So this way, unloading the muscle and improving the gas exchange will also improve the ventilator control center input and output. And positive pressure ventilation affects it, and it in a way that it affects the gas exchange, ventilatory muscle loading, and even cortical influences that are affected by the sense of dyspnea or anxiety. Now, this next is alveolar recruitment and gas exchange. So it is also very important benefit of non-invasive ventilation or positive pressure ventilation, because many times we see that there is linear atelectasis, basal atelectasis, and because many post-op patients with especially abdominal surgery or because of the pain, there is atelectasis of the lung, and that causes hypoxia. So alveolar recruitment, it causes caused by the positive pressure ventilation, it improves the lung compliance, improves oxygenation. So this is x-axis is the pressure, y-axis is the volume. As we are increasing the pressure, the volume initially is increasing slowly because still all the alveoli are not open. So here it is low FRC. Now at optimal pressure, the alveoli will open most, and here we will get the maximum increase in the tidal volume also. So that is the ideal FRC. Once we are increasing the pressure even more, it will come on the flattening side of the curve. There will be the highest FRC, but that will cause over distension and it will cause more injury of the lung than the benefit. So the steep part will be the ideal FRC. So the next is PEEP leading to alveolar recruitment is beneficial in various ways. Like it improves the VQ mismatch, opening the atelectatic part of the alveoli. It prevents the shear stress because if the alveoli are collapsing, with every positive pressure breath, it will open and closes completely. So if we are applying PEEP, it will keep that is the positive end expiratory pressure. So at the end of the expiration also, there will be a slight positive pressure in the alveoli, which will keep the alveoli open, and it will avoid the alveoli from completely closing to completely open during the inspiration. So it will be open slightly and then open, it will distend from there. So this way the shear stress will be less and the less risk of ventilator-induced lung injury. And also PEEP prevents the surfactant breakdown in collapsing alveoli and thus improves the lung compliance. Now, these are the respiratory part of the NIV, physiological effects of NIV. So now we are coming to other effects of NIV on other system. So it is helpful in maintaining upper airway patency. Very well known indication is in obstructive sleep apnea, where this positive upper airway pressure will keep the airway spleens open, the collapsed upper airway structures during sleep. Then reducing imposed triggering loads from auto-PEEP. So auto-PEEP is a very big problem in obstructive airway diseases. So this auto-PEEP will increases the work of breathing, because we know that if patient is spontaneously breathing, then auto-PEEP causing the positive alveolar pressure. And so if the patient wants to trigger the breath, patient has to overcome that positive pressure of the auto-PEEP, and then only it will trigger the pressure breath, because of the difference in the pressures at the airway mouth opening and the alveolar level. So this will increase the patient's work of breathing. And this can be intolerable isometric like load on inspiratory muscle, leading to respiratory failure. So this is how it is happening. Air is trapped in auto-PEEP. So this is pressure here is 0. Obstructive airway disease, alveolar pressure plus 10. So obviously if the patient has to trigger a breath, it has to come in the negative, because otherwise how air is going to flow from the 0 to plus. So patient has to overcome this plus 10 centimeter of water auto-PEEP, and it increases the work of breathing, leading ultimately to respiratory failure. So if we are applying external PEEP that is just below the auto-PEEP, then it will overcome this pressure, and then from here patient has to generate a small amount of pressure only, negative intrathoracic pressure, to trigger the breath and prevents the it decreases the work of breathing. Now the downside is ventilator induced lung injury. So ventilator with the interaction of the respiratory system mechanics and the mechanical ventilator, what we have said, patient might generate high tidal volume, or if we are applying high PEEP in those patients where it is not needed, or if there is intrinsic PEEP. So it causes over distension of the alveoli, and that will cause alveolar injury, pneumothorax also. Second is if there is risk of ventilator induced lung injury, and it can be reduced during NIV, because if we are using NIV, we should observe and monitor the tidal volume delivered. the pressure that patient is generating, and the peak pressure that is going. And PEEP also, we should optimize. If it is where high PEEP is needed, we should know it very carefully. So the ideal, what we have all learned, that if we should always ventilate with the lung protective settings, that is transpulmonary and inspiratory pressure of 30 centimeter of water, tidal volume 8 ml per kg, ideal body weight. This I'm talking if patient is not in ARDS, so you can go till 8 ml per kg ideal body weight, and driving pressure 15 centimeter of water, and judicious use of PEEP, balancing end inspiratory distending pressure and FiO2 to meet PO2 target. Now, second very important organ which interacts with the positive pressure is heart-lung interactions, which is both beneficial and harmful. So, in healthy heart, that these are in hypovolemia or preload dependent heart. So cardiac output decreases in positive pressure ventilation. How it is happening? We are giving positive intrathoracic pressure, that is increasing the right atrial pressure, and it is if we are using blood, there is a venous return to the heart, because there is a difference between the mean systolic filling pressure and the right atrial pressure. We are increasing the right atrial pressure, so that gradient is decreasing. So that is decreasing the venous return, and decreasing the venous return on the right side will decrease the stroke volume. Second is, we in a positive pressure ventilation, if patient is hypovolemic, so in that condition we are increasing the pulmonary vascular resistance, and because distending alveoli will easily put pressure on the pulmonary vasculature, and it will increase the RV afterload further compromising the RV output. The third is increasing the RV pressure. It might cause leftward shift of the interventricular septum in hypovolemic heart or preload dependent heart. So we might see that cardiac output decreases in these patients. In failing heart, or where it is preload independent, so it has shown beneficial effect. How? So we are giving PEEP. PEEP decreases the left ventricular afterload by decreasing the transmural pressure, which is the left ventricular pressure minus the intra-aortic pressure. So this will decrease the transmural pressure, which reflects the left ventricular afterload. And second is diastolic filling, which is happening because of the positive pressure. Diastolic filling happening when we are giving positive pressure ventilation. So with the intrathoracic blood is getting squeezed from the intrapulmonary region to the left ventricle. So this is falling in the productive part of the Starling curve, where there is not much stretch of the myocardium. So cardiac output will be better. And third is, it is definitely reducing the oxygen demand and workload of the failing heart by reducing the ventricular afterload. And also we are offloading the respiratory muscle also, so oxygen demand will be less. So this is the flow chart with a positive intrapleural pressure, increased right atrial pressure, decreases mean systolic filling pressure minus right atrial pressure gradient, decreased venous return, RV preload decreases, stroke volume decreases. Now on this left side, decreased left ventricle transmural pressure, decreased LV afterload, potential increase in the LV stroke volume, and significant in benefit in cardiac failure. Now, production of auto PEEP. So high levels of minute ventilation from NIV support can lead to development of auto PEEP if we are not careful about the ventilator setting. We have set the pressure which is generating high tidal volume, but we are not giving enough time for the expiration to occur. Then it can accumulate it can keep on increasing the auto PEEP, and then this can again cause the respiratory failure even the patient is on NIV. So whenever we have to monitor that also. So here, if the patient is generating tidal volume, then definitely cycling is going to be the issue, because cycling is happening, either it is time cycle, or if it is spontaneous NIV pressure support, it is going to be the flow cycle or pressure cycle in the other positive pressure ventilation. So if there is auto PEEP, definitely the flow is not reaching and to zero, and cycling can get hampered from the expiration to inspiration again. So it can, we need to look after this, and we can address it by changing the cycling threshold or time cycle. So we need to do some settings in the our ventilator that we are going to discuss in detail tomorrow when we will discuss hands-on. The next is patient ventilator interactions. Because of the presence of leaks and mask dead space volume, it reduces the sensitivity and responsiveness of the ventilator report sensing capabilities and flow responsiveness. So this can cause significant trigger issues like delays or missed trigger, double trigger, flow delivery mismatch with effort, and cycling asynchronies. So again, this can cause invasive ventilator NIV failure and can land up on putting the patient on invasive ventilator. So we should optimize it to avoid asynchrony. So minimize the leak and adequately set the NIV to meet the patient demand. So these are few newer modes like pressure assist ventilation and NAVA, where this asynchrony can be minimized and can be beneficial in cases where we can avoid invasive ventilation. So to summarize this, NIV has a number of physiologic effects similar to invasive positive pressure ventilation, and major effects of NIV are to augment minute ventilation, reduce muscle loading, and this can have profound effect on patients' ventilator control center, especially in chronic uh, patients, like in COPD patients, where we know that there is always more workload on the respiratory muscle. So if we are applying NIV, and especially overnight NIV, this can easily offload that workload on the respiratory muscle and can regularize the respiratory center. So because NIV can be supplied with PEEP, so it can help in alveolar recruitment, and also it make possible the ventilator weaning if there is auto PEEP. So NIV mask or CPAP can maintain upper airway patency, so useful in obstructive sleep apnea, and can have multiple effects on cardiac function. So by reducing venous return, can help in heart failure or fluid overload patient to clear, and applying the PEEP can improve the cardiac output and better fluid clearance. It also increases the right ventricular afterload, but it can also function to reduce the left ventricular afterload. So we have to be, we need to calculate that as per the patient's profile, which case patient is going to cause which patient can have hypotension after applying positive pressure ventilation, and how we can adequately correct it. And definitely it is not free of any risk. So potential detrimental physiologic effects of NIV are ventilator-induced lung injury. So in case of ARDS, where we know that lung protective ventilation is very important with ventilating with low tidal volume and optimizing the PEEP. So in mild ARDS, we can use NIV cautiously, but definitely in case of severe ARDS, where we cannot control the delivered tidal volume, so in those cases, it can cause ventilator-induced lung injury. Then auto PEEP development in obstructive airway diseases, because we cannot completely control this, and discomfort or muscle overload from poor patient ventilator interactions. So that's all from my side. I'm okay, I will happy to take any question or any doubts. So please ask if you have.
I think, Ritika,
Yes.
tomorrow when we have all the subsequent, let people go through and understand the overall mechanistic principles. And our intent is also that when we explain most of it in during the interactive session, right? Let them understand with the machine in person itself. So that could
Yes.
be also a good way to learn about the NIV process. So if there are no questions, then we will go move towards the next one, which is Dr. Pragya Chaudhary. Pragya, are you busy? Are you ready with your deliberation, Dr. Pragya?
Hello. Am I
Ah,
audible, sir? Am I audible, sir?
yes, yes, you are.
Yes, I'm here,
But I
sir.
think there are a couple of people who have logged in from the
Just a
same
minute,
room.
I'll load my
So,
presentation.
if one of you can uh, sort of say mute or you can unblock. You you had been audible, but now I can't see or listen to you. Yes, it's audible, it's visible, but not full screen.
Are my slides audible, sir? Sorry. Are my slides visible?
Slides are visible and your voice is audible. But yes,
Sir
now
was
it is
on
full
mute.
screen. Now, sir is not on
Sir, I
mute.
think you're on mute, sir.
No, I'm completely not on mute.
Sorry, sir, I was on mute. Okay. Good evening, everybody. At the
Yes.
outset, I would first like to thank Dr. Arindam, Dr. Rahul Pandit, Dr. Ritika for giving me this opportunity. I know initially I thought it's a very simple topic, options of non-invasive supports, but as and when I was preparing the presentation, I realized how complicated it is, and I kind of remembered all the difficulties that we faced while adjusting settings for the portable pipes in the ICU when we were starting uh, our profession. So I'll try to give a brief gist of it, and probably tomorrow with the hands-on, we'll have a better idea of how to make the settings on the portable ventilators. Uh, okay, that's good. So basically, the concept of non-invasive positive pressure ventilation is either it's a CPAP or a BiPAP mode, or in the ICU grade ventilators, we have the pressure support and the pressure control mode. Uh, Yesterday, Dr. Stuti had discussed a bit on it. I will still cover it again once more in this presentation. The goal entirely is to improve the oxygenation along with elimination of the carbon dioxide. Uh, Simultaneously reducing the work of breathing of the patient. Now, this is delivered in a mechanical ventilation or an invasive ventilation where we are using an endotracheal tube as the interface. Here, we are using a tight fitting mask, which can be a nasal mask, which can be a oronasal mask, or in very rare cases, we use a helmet also. Now, in this condition, like a well inflated, adequately inflated cuff is important in case of mechanical ventilation to provide proper tidal volumes. A good seal is necessary to deserve the desired positive pressure. And this mode of ventilation reliably titrates FiO2 up to 100% when connected to a high pressure oxygen source. And the oxygen is, of course, blended with room air inside the machine. Now, if you see the picture down, it's just a pictorial representation of all the various types of interfaces that we have, uh, which is a face mask, which is a face mask, a nasal mask. Then we have the pediatric or the neonatal masks. We also have the helmet, which I'll show in the subsequent slides. So in these patients, selecting the interface type is very important because that is what determines the compliance and cooperation of your patient. So the choice between the interface is, of course, majorly taken, the major factor that is taken into consideration is your patient comfort. And if the patient has claustrophobia, then preferably a nasal mask is required. The only drawback is these masks are not very readily available. We usually have a face mask which is readily available in different sizes, small, medium, and large. But when we talk about nasal masks, they're not readily available, or sometimes they need to be customized in patients who are known case of sleep apnea, who are more comfortable with a nasal mask. They usually get the mask customized to their face so that a proper fitting and comfort is taken into consideration. So, in brief, we will see what are the advantages and disadvantages of the various interfaces that we have. In case of a nasal mask, it is easy for secretion clearance because the oral cavity is open. The patients feel less claustrophobic. They can still talk, and sometimes the patients can probably eat also with the mask on, and there is less dead space. But the negative or the disadvantages of a nasal mask is there is higher resistance through the nasal passages. And if your patient has any kind of a nasal obstruction, then the effect of the positive pressure ventilation is not proper. It can sometimes cause nasal irritation, rhinorrhea, and there is a significant chance that the patient might keep his mouth open. That results in inadequate delivery of the positive pressure ventilation and also can result in mouth dryness. Whereas the oronasal mask is the one that we usually routinely use in day-to-day practice. It has a better leak control, but at the same time, it has a lot of dead space. And if your patient has an unfortunate incident of vomiting with the mask on, the chances of aspiration is high. And at the same time, they're not able to clear out their secretions very frequently or very easily. So the chances of aspiration increases. And the major complaint that we usually get from the patients is claustrophobia. And in this case, if there is any ventilator malfunction or there is any error in the settings that happens on the ventilator, then yes, definitely the respiratory compromise can happen. It can result in asphyxiation also. And of course, with the mask, the patient cannot talk or eat. So that is one major complaint they usually have. Mouthpiece is something which we do not use in a regular practice, so I'm not going to talk about that. The total face mask is something which is slightly bigger than your oronasal mask, where the upper margin of the interface goes up till your forehead. Uh, the benefit of this is you don't have to go with the size of the mask. You don't have to struggle and measure for the proper size of the mask. It's a single size and one size fits all is the advantage of it. There's less risk of facial skin breakdown because usually when we see our oronasal mask, there's a lot of issue with bridge of the nose necrosis that happens, pressure sores, skin peel that happens on the chin and the bridge of the nose. So that is less with a total face mask. But again, the drawback is potentially more dead space as compared to a oronasal mask. Because your eyes are also included in the interface, there is a potential for drying of the eyes. And when we are using a total face mask, we cannot deliver aerosol medications. As I know that most of you, when you're using a BiPAP, we connect the nebulizer within the circuit and we still deliver the aerosol medications. Now, last is the helmet, which is most comfortable for some patients who uh, there is very minimal risk of facial skin breakdown. But yes, the major disadvantages are first is you cannot, there's a lot of patient ventilator dysynchrony that happens in this. Uh, it does not give the maximum benefit of a positive pressure ventilation where you are unloading the respiratory muscle fatigue with this kind of helmet. Uh, Again, aerosolized medications cannot be delivered, and the risk of rebreathing is very high in this kind of a interface. Now, whenever we are considering non-invasive positive pressure ventilation, there are few things that we need to remember. One is whenever you use the NIV, we should not have a false sense of security that, okay, I've put the patient on NIV, so I am fine. It needs very close monitoring, and using of the NIV should not delay a potential intubation, because that would further increase the delayed intubation will further increase the morbidity and mortality of the patient. Again, whenever you're setting your pressure support on the ventilator or the on the pressure control mode, always start at the lower volumes. It is a bedside monitoring system that whenever you initiate the patient on an NIV, you need to be at the bedside of the patient. It's not just that you tell the sister, ki, okay, this is the settings, or I have put the settings on the ventilator, so you can go ahead and do it. You can go ahead and start the ventilation. It is not that way. You need to talk to the patient. You need to explain the patient the procedure. You need to tell them that there's going to be a mask on your face that is going to be held with some pressure. And what we were taught and what we do in practice is whenever the first we are initiating a patient on NIV, we hold the mask with our hand. We do not put on the straps. We do not fix the mask. We just hold the mask. We give the patient a little while, a couple of minutes to get used to the interface. And then gradually you increase the pressure with which you are holding the mask. And once you look at the patient, you see that the patient is comfortable, the patient is able to breathe along with the machine, then that is the time when you fix your head straps and fix your mask. Then you ensure that there's no leakage, etc. Now, why is this important? Because if you just start, suppose I start off with a pressure support of 14, and if my patient is generating a very high tidal volume on that 14 pressure support, and I have not monitored the patient bedside when I've initiated the therapy, there is a significant chance of volume trauma to the patient. Again, whenever we are initiating the NIV, we have a lot of tapes, etc., available right now to reduce the pressure related injuries to the nasal bridge and the chin. And it is always important that we take the precautions beforehand. Once the other more concerning consideration is nutrition. So whenever your patient is on NIV, sometimes if you're just giving it as a support intermittently, then probably the nutrition is usually not hampered. But in case if your patient is a case of acute hypoxemic respiratory failure and you are trying to avoid intubation by keeping the patient on NIV, where your patient is on NIV for a significant amount of time, like probably 16 hours, 18 hours, 20 hours in a day, then your feeding nutrition is hampered. And in those patients, we need to have a forethought before itself and have a rise tube in place so that early enteral feeding can be established. And again, this enteral, the NJ tube, the nasogastric tube is of course going to help you with uh, the gastric insufflation that happens with the non-invasive ventilation with our ICU grade ventilators. Again, it is important to train your staff at the bedside. It is important to train your staff as to what needs to be monitored. It is just not that your patient is put on the ventilator or an NIV and everything is going to be fine. So the staff should be aware of what to monitor on the ventilator, the tidal volumes, the respiratory rate, along with that, what are the hemodynamic changes that are happening with the initiation of the NIV. The various modalities or the various non-invasive options that we have. First is your the ICU grade ventilators, which have the NIV option of a pressure support and a pressure control. This was actually discussed yesterday, so I don't have slides for that, but I'll just shortly discuss that as well. So whenever we are talking about a pressure support ventilation in a non-invasive ventilator, there are three parameters that we set on the ventilator. One is your FiO2, the other is your PEEP, and the the pressure support. Now, for any patient, whenever you're initiating an NIV, you start at a PEEP of 5, and you start at a pressure support of around 10 or sometimes maybe 8 based on your patient build. If your patient is a thin, lean build patient, you can start at lower pressures. Now, the benefit of pressure support is the control is completely with the patient. The patient is going to determine when the cycle begins, when the inspiratory cycle begins, and how much tidal volume is going to be generated. And in case if the patient is not triggering a breath, of course, the ventilator is going to support. Then we have the pressure control ventilation in the NIV mode, where you have one additional factor, that is the rate. So you basically set a backup rate. So in case if your patient is not taking adequate breaths, the machine ensures that that number of breaths are delivered to the patient. Suppose if I set a rate of 14, in case if the patient is a little uh, bradypneic and they are breathing only at 8 to 9 times per minute, then the ventilator compensates for the lost count and it maintains the minute ventilation that is required. Now, if we move on from the ICU grade ventilators to our portable ventilators, the most common modes that we hear are your CPAP and your BiPAP. Now, this slide shows the basic difference between your CPAP and your BiPAP. So, CPAP stands for a continuous level of positive end expiratory pressure, and that is nothing equivalent to your PEEP. Though the terminologies are different, what you call as CPAP is similar to PEEP, and it is also the same as your EPAP on a BiPAP machine. It's just a different terminology, but the basic underlying physiology is the same. So what is CPAP is a continuous level of positive pressure, positive end expiratory pressure. Now this is used to improve hypoxemia by recruiting a collapsed alveoli. Now there is no inspiratory pressure or rather there's no inspiratory pressure component in a CPAP. So if at all you want to treat only a hypoxemia, you can always opt for a CPAP mode of ventilation. Now, when you're talking about BiPAP, it provides, it's in the name itself, BiPAP. So there are two different pressures that are happening. So BiPAP provides one pressure, that is your inspiratory pressure, that is called the IPAP, and separately an expiratory pressure that is called your EPAP. The addition of IPAP reduces the work of breathing. That is the difference between your IPAP and EPAP is the delta P. So when you have a patient with hypoxemia as well as hypercapnia, that is the patient who is going to benefit with your BiPAP, because the difference in the pressure is what helps in washing out your CO2 as well as reduce the work of breathing. Now, how do we initiate a CPAP? Again, always if your patient has a good oxygenation, you don't necessarily have to start with an FiO2 of 100%. You can always start with 50-60% and then you can titrate accordingly. You start with a CPAP of 5 centimeters water, and every 5 minutes you titrate the CPAP by increasing it by 2 to 4 centimeters of water. Now usually when you keep increasing it, you look for a good clinical response. Now, what do we call a good clinical response is one is majorly, first is your patient should be comfortable. Now, your patient is going to be comfortable only when you have explained the interface properly to the patient. You have explained how they are supposed to breathe, how they need to keep their mouth closed, they need to breathe through the nose along with the ventilator. So once you explain it, now while you're titrating your CPAP gradually, you need to make sure that you're not going above 12 centimeters of water, because at this pressure, there's going to be overdistension of your alveoli and it is going to be counterproductive. Similarly, as you're titrating your CPAP upwards, you need to reduce your FiO2 to the lowest setting that gives you a saturation above 90 to 92%. Again, whenever you're increasing your CPAP or decreasing your CPAP or decreasing your FiO2, please make sure that you have a close look at your patient. See if they are having an improved work of breathing, or the tachypnea is settling down, or are they becoming more tachypnic. Is there any accessory muscle of respiration that they are using, right? So make sure that the patient is comfortable, and that is how you assess your clinical response. Again, as your pressures are going up, they can cause overdistension of the alveoli and lung injury, as well as gastric insufflation and risk of aspiration. Now, all patients may not have a Riles tube in situ, so that's why you need to be careful about the gastric insufflation as well. So CPAP, you just have to set a single pressure, and that is going to help with the oxygenation of the patient. Now, when we come to BiPAP, there are three major modes that we usually see in all of the portable BiPAPs that we usually use in the ICUs. One is called the S mode, that is your spontaneous mode. In the spontaneous mode, what happens is all the breaths are patient triggered and cycled. That is, the patient determines uh, when the cycle switches from inspiration to expiration, or when the breath is triggered. Now, the machine delivers a preset pressure during inspiration and expiration. There are no automatic breaths that are delivered. And patient initiates all the breaths, and the machine responds to the inspiration and the expiration. Now, this is your spontaneous. The other one, we'll discuss the ST mode later. I'll discuss the timed mode first. In the timed mode, the machine does not rely on a patient breath or a trigger from the patient. All the breaths are automatically delivered and set. This is basically a machine cycle and a machine triggered mode. Now, what we use on day-to-day basis is a combination of both of them. That is called your ST mode. In ST mode, the breaths are patient triggered as well as machine triggered, and patient cycle and machine cycle. Now, what does that mean? So, once we go to the next slide, you'll get a better idea of how the settings are done, and that will explain. But in ST mode, what we do is we set up backup breaths as well, and also a inspiratory time. Now, what is inspiratory time is, if the patient do not initiate a breath during that set time, then the machine automatically delivers the breath. So basically, inspiratory time is the time till which uh, the machine will wait for the patient to deliver a breath. So inspiratory time, usually in a pressure controlled mode of ventilation, it is determined by the ventilator. But in a pressure support mode, it is determined by your patient. The default inspiratory times are usually 0.8 to 1 second. And for most adult patients, 1 second is a good enough inspiratory time. Now, the other parameter which we need to know about in non-invasive ventilator or BiPAPs is called the rise time. Now, what is rise time is the time taken from the increase in pressure from your EPAP to the IPAP. So, how rapidly the pressure is increasing from EPAP to IPAP determines your peak inspiratory flows. So, if you increase your rise time, it reduces the peak inspiratory flows and in turn increases the comfort for your patient. Whenever we are using any mode of positive pressure ventilation, the whole point is whenever your patient is in respiratory distress, their peak inspiratory flow rates are very high. So you want to decrease the peak inspiratory flow rates. So usually the rise time ranges from 1 to 4 seconds, and if you can adjust it based on how your patient is doing. Now, whenever we are going to initiate a BiPAP, the ST mode is actually colloquially used for BiPAP as well. So the common BiPAP initiation pressures are, you start with a IPAP of 10 centimeters or an EPAP of 5 centimeters. So the basic rule is you keep a EPAP of minimum of 4, and you keep a delta P, that is the difference between an IPAP and your EPAP, should be at least 5 to 7. So if you see the settings that are written on the screen, if you're keeping an IPAP of 10 centimeters, you keep an IPAP of 5 so that your delta pressure is 5. If you're keeping an IPAP of 15, then you need to increase your EPAP to 10 centimeters of water so that the delta pressures are maintained at 5. Sometimes if your patients are hypercapnic, you want to have a better washout of CO2, you can increase the delta P up till 7 so that it helps in better washout of CO2 as well. Again, you start with an FiO2 of 100% and you titrate down to the amount needed to achieve the target saturation. Usually, you can have a target of 90 to 92% based on your patient's clinical condition. Again, always use the lowest FiO2 necessary. Now, how do you titrate the BiPAP? Now, we have seen the initiation settings. How do you titrate? So, basically, your EPAP or your PEEP or your CPAP is basically what is helping you treat the hypoxemic component of the respiratory failure. So, you keep increasing your EPAP at increments of 2 to 3 centimeters water to a maximum of 15 centimeters water. With every change in EPAP, you need to monitor the patient for 3 to 5 minutes for your clinical response. Again, your clinical response is the same. Patient's comfort, work of breathing, hemodynamics, the saturation. Now, your IPAP is what helps with the work of breathing. Now, always increase the IPAP when increasing the EPAP so that the delta P is always between a range of 5 to 10. Now your IPAP is supposed to, the maximum IPAP that you are supposed to set is 20 centimeters of water. If you're requiring any pressures more than 16 to 18 centimeters of water on a BiPAP, you're requiring an IPAP of more than 16 to 18, it means that your patient is not getting benefited from your BiPAP and you probably need to reevaluate your patient's clinical condition, whether they require a mechanical ventilation and intubation. Again, with every change, you need to monitor the patient for 3 to 5 minutes for any hemodynamic compromise or clinical deterioration. We have discussed this. Patient should be comfortable, improved work of breathing, reduced RR, improved saturation, stable hemodynamics, and mental status are the good clinical responses that we look at. Now, whenever we are using non-invasive positive pressure ventilation, in case of ICU grade ventilators or your portable BiPAPs, you need to monitor the tidal volumes also. Sometimes you are giving a IPAP of 16, 14, but your patient's tidal volumes are not adequate. If they are not generating a tidal volume of 6 to 8 milliliter per kg body weight, that means your BiPAP support is not adequate for the patient. Or if they are generating extremely high tidal volumes, then you need to reduce your pressures because that would cause volume trauma. Again, certain patient special conditions where you need to be careful when you're thinking about initiating NIV is your patient needs to be conscious and coherent when being initiated on an NIV. A drowsy patient or an agitated patient or somebody who cannot protect their airway are not the right candidates for non-invasive ventilation. In patients who have multi-organ failure and in addition to hemodynamic instability, if there is acute respiratory failure and you're thinking of using an NIV, it is probably a imminent arrest situation and you need to reevaluate your decision of using the NIV. If there are any anatomic barriers that do not permit adequate facial mask seal, if there is any facial trauma, past history of facial trauma or any facial surgical history, probably an IV is not a appropriate option for them. If there's a lot of respiratory secretions, then yes, you need to reevaluate whether using a face mask is going to be beneficial. You may choose a nasal interface in those patients. And if the patient is having active vomiting, then yes, the risk of aspiration is increased. So you need to reassess your decisions. Now, one more mode of ventilation that we frequently use in portable BiPAP machines is your AVAPs. Now, what is AVAPs? It stands for Adaptive Volume Assured Pressure Support. If we break down the title, adaptive, so it is a hybrid mode that adapts itself, volume assured. It delivers a set volume within a pressure range that you have set. So it is basically analogous to your PRVC or a volume control mode on the invasive ventilation. the benefit of this is it ensures minimum ventilation. Suppose there is one additional setting that we do in an AVAP setting. Whenever you are initiating an AVAP's machine, in addition to the IPAP and the EPAP, you set a backup rate. You also set a tidal volume that you want generated for the patient. Again, when you're setting the IPAP, there are two values that you need to set. That is your IPAP minimum and your IPAP maximum. Now, what are these values is, IPAP minimum is basically the same number that you would set in a BiPAP machine. In the ST mode, whatever IPAP you're setting is the IPAP minimum that is going to be there. And your IPAP maximum is usually 1 to 3 times plus your IPAP minimum. Now, what happens is with whenever once you initiate the patient on AVAPs, the machine automatically adjusts itself in that range of the IPAP maximum and minimum along with your EPAP to generate that fixed amount of tidal volume. So just once, one thing I would like to repeat and re-emphasize again is, in your ICU grade ventilators, whenever you're using an NIV pressure support and you want to switch that patient to a portable BiPAP. Now, what are the settings that we have on the NIV? You have a PEEP and you have a pressure support. Now, when you're translating the same to a portable BiPAP, there you have two numbers, that is your IPAP and your EPAP. The IPAP is going to be a sum of your pressure support and the PEEP. If I have a patient who is on a PEEP of 5 and a pressure support of 10, if I have to give this particular patient a portable BiPAP trial, my settings would be IPAP would be 15. That is the sum of my pressure support and the PEEP, and my EPAP is going to be same as the PEEP. So please remember, I think Dr. Stuti had also emphasized on this yesterday. It is just not that your pressure support is equal to IPAP and your PEEP is equal to EPAP. Your pressure support plus PEEP is equal to IPAP. Okay, please remember that. Now, just to summarize, the evidence-based indications for NIV, the strongest evidence, that is your meta-analysis or a multi-center RCTs, that is your level A evidence, is for acute exacerbation of COPD to facilitate weaning in COPD patients, acute cardiogenic pulmonary edema, and in immunocompromised patients in whom we do not want to put them on a ventilator because of the risk of infections. Then we have the level B evidence, where you have patients with post-operative respiratory failure, patients with motor neuron diseases, or if the family chooses to go for a do not intubation protocol because of a poor outcome scenario, or patients with cystic fibrosis or obesity hypoventilation. Now, the least evidence is in forms of cohort series or a case report is for restrictive disorders or upper airway obstruction and acute respiratory distress syndromes. The final modality of non-invasive option that we have is the high flow nasal cannula or the high flow nasal oxygen. Now, this is a therapy in which the respiratory support is delivered in the form of heated and humidified gas with a controlled concentration of oxygen. If you see the picture, there's an oxygen or an air blender. The oxygen goes through a heated humidifier, and then from there it is delivered to the patient via soft nasal prongs. Now, how the mechanism of action of a high flow nasal cannula is, by the high flow, during the phase of expiration, you are giving a PEEP effect. At the same time, because of the PEEP, you are creating alveolar recruitment, and that results in your dead space washout. The same high flow during the inspiration, it basically provides the peak inspiratory flow that is required by the patient. Again, the alveolar recruitment also causes a redistribution of your tidal volume. Now, why humidification improves the outcome in HFNC patients is, It preserves the nasal mucosa and it is more comfortable. If when we are using a nasal cannula and we are delivering 4 liters of oxygen, if you increase the flow to 5 liters or 6 liters, your patient starts complaining of drying of the nasal mucosa. Some patients go to an extent that they start having nasal bleeding. That is because we are giving dry air. Now imagine you're giving up to 60 liters of flow through the same nasal cannula and your patient is still comfortable. That is because we are giving humidified and heated gas flows. And this also causes enhanced mucociliary clearance and it improves the function. Next is the high FiO2 that is delivered via the HFNC. It permits a constant oxygen delivery even with high inspiratory flows from intense respiration efforts. So if we see the delivery systems of oxygen, we have the low oxygen delivery system and the high oxygen delivery systems, which I'll talk in the next slide and how it varies. So the high flow causes a washing out of the nasopharyngeal dead space. If you see the picture on the right side, at zero flow in the nasopharyngeal cavity, what you see is the carbon dioxide. But as you increase the flow to 30 liters, there is a oxygen reservoir that is building and that is washing out the CO2 as well as decreasing the CO2 rebreathing. If you look at the flow at 60 liters per minute, there is almost major washout of the CO2 that is there and a good oxygen reservoir has been built up. Now, because of the high flows, there is a mechanical splinting of the nasopharynx that happens and it prevents the supraglottic airway collapse and decreases the nasopharyngeal resistance. Now, the PEEP or the CPAP effect that is given by a HFNC is not consistently measured or doesn't remain very consistent. It is very much variable if your patient has their mouth closed or open. But the average PEEP or the CPAP that is delivered with an HFNC ranges anywhere between 3 to 5 centimeters of water. And this PEEP effect or your CPAP improves the lung compliance and it reduces your work of breathing. Now, when we compare the high flow and the low flow nasal cannula therapy, with your conventional oxygen delivery devices, the peak inspiratory flow rate is peak inspiratory flow rate of the patient in respiratory distress exceeds the delivered flow of oxygen. Whenever your peak inspiratory flow rates delivered are less than the patient's requirement, there is entrainment of air that happens and it causes dilution of the oxygen that we are delivering to the patient. Hence, with a low flow device, the oxygen that is delivered is always variable because there is always dilution with the ambient air. But in a high flow delivery system, we are delivering about 60 liters of oxygen per minute to the patient. That meets the patient's inspiratory demands and a fixed oxygen is delivered to the patient. There is no entrapment of ambient air that happens. There is no dilution of air that happens. And a fixed O2, whatever you are determining on your device, is delivered to the patient. Now, the various clinical applications of HFNC, you can use them for procedures when in procedures like endoscopy, where you want to enhance the oxygenation of the patient because they receive some amount of sedation. You can use it for those procedures. You can also use it for no DSAT technique when you're facing a difficult airway intubation for continuous oxygenation during the laryngoscopy. In patients with hypoxemic respiratory failure secondary to ARDS or in pneumonia, or in patients with idiopathic pulmonary fibrosis where invasive ventilation can be detrimental, in those patients to reduce the work of breathing, to reduce the respiratory rate, HFNC can be used. In ARDS, it is only proven to be useful in case of mild ARDS where your PF ratios are more than 200 to 250, or in case of early ARDS. In patients with cardiogenic pulmonary edema, it reduces the work of breathing, especially if your patient is non-compliant with an NIV. Of course, it is proven not to be inferior, but at the same time, NIV definitely has a better outcome in case of cardiogenic pulmonary edema. Also, in patients post-operatively undergoing cardiothoracic surgery or any vascular surgery, or as a post-extubation support, respiratory support in case of high-risk patients, HFNC has a good role. In patients who are on a do not intubate protocol because of poor outcomes in case of advanced malignancy patients, in those patients, HFNC is known to improve oxygenation and respiratory mechanics. Now, contraindications, because the only interface that we have is a nasal prongs. Anything related to the nostrils, like if there is epistaxis, if there is any history of surgery to the nose, if there is a nasal fracture or a nasal tumor or a base of skull fracture, then these are the contraindications for using an HFNC. Now, how do we set the HFNC for a patient? There are only two parameters that need to be set on the HFNC. Of course, before you initiate the HFNC, you need to make sure that your HFNC machine is turned on and it is actually heated to 37 degrees. When you turn on the machine immediately, it is probably around 31, 32 degrees only. You need to wait for 15-20 minutes for the machine to heat up, for the humidifier to heat up, and then you start the machine. Otherwise, your patient is going to be extremely uncomfortable if you give a flow of 25 to 30 liters at a temperature of 31 degrees centigrade. The two parameters that need to be set are your flow rate and your FiO2. Prefer to set the flow rate first, typically at 20 to 35 liters per minute. The range you can set is 5 to 60 liters per minute with a pediatric, where in pediatrics you use less than 20 liters. The FiO2 ranges from 21 to 100%, and you set the FiO2 based on your desired peripheral oxygen saturation. Now, gradually, once you start your flow rate at 35, you let the patient get accustomed to the flow. You gradually increase the flow in aliquots of 5 to 10 liters per minute. And if the respiratory rate fails to improve, oxygenation fails to adequately improve, or if the breathing remains labored, you can further go up till 60 liters per minute. Now, increasing the flow rate and the FiO2 will both result in improved peripheral oxygen saturation, but prefer to maximize the flow rate first, because this is what you're trying to match the peak inspiratory flow requirements of the patient. So that reduces your work of breathing also. So first, maximize your flow rate, and then despite a flow rate of 60%, so 60 liters, if your patient is not having adequate oxygen saturation, then you can increase the FiO2. But once if your FiO2 requirement is going beyond 60%, you need to closely monitor your patient for failure of HFNC. Temperature is again need to be maintained at 37 degrees centigrade. HFNC is usually well tolerated and is administered for prolonged periods, even days. And then how do you wean your patient from HFNC is, once your patient's clinical condition has stabilized, once the flow rates based on your ABG, based on your PF ratios, you can gradually start reducing your FiO2 and your flow rates. Once the flow rates reach less than 20 liters per minute and your FiO2 is less than 50%, you can switch to your conventional low flow nasal cannula therapy. Now, how do we monitor the effectiveness of HFNC? There is a ROX index that has been defined. It is the ratio of your oxygen saturation as measured by the SpO2 or the FiO2 to the respiratory rate. So the formula is SpO2 by FiO2 divided by your respiratory rate. In patients with hypoxemic respiratory failure, the ROX index can be used after HFNC therapy has been initiated to help identify those who are at high risk of intubation. Now they had given cutoffs that a ROX index of more than 4.88 after 2 hours of treatment indicates a high probability that intubation will not be necessary. So a high ROX index means that your patient is responding to your HFNC therapy, and a ROX index less than 3.85 indicates a higher risk of treatment failure. It's a very simple index that we can calculate bedside, as similar to our PF ratio that we do with our APGs. You have all the parameters at your bedside. You have you don't even need a APG for this. You have the saturation on your monitor. You know the FiO2 that you're delivering to the patient. You have the respiratory rate at which the patient is breathing, and we can easily calculate this at the bedside and can monitor the effectiveness of the HFNC. Now, a study was done to determine the sensitivity of this ROX index. This was a study done in 2016 or 15. It is a 2-year multi-center prospective observational cohort study which included patients with pneumonia treated with HFNC. So they had monitored the ROX scoring at 2 hours, 6 hours, and 12 hours. And again, they concluded the same thing, that if your ROX index is more than 4.88 after 12 hours of initiation of HFNC, the chances of requirement of mechanical ventilation is very less. But again, if it is less than 3.85, consider endotracheal intubation at the earliest. The effectiveness of the high flow oxygen therapy in acute hypoxic respiratory failure has been very well established by the very famous Florali trial. This was a randomized clinical trial which was done in France. It had about around 310 patients who were randomized to 3 groups with high flow oxygen, non-invasive ventilatory group, and the standard oxygen group. Though the 28-day intubation rate was similar in all of the 3 categories, the 90-day mortality was significantly reduced in the patients who received HFNC. Again, there's another study which compared the high flow nasal oxygen versus non-invasive positive airway pressure in hypoxemic patients after cardiothoracic surgery. So in this also, though the rate of reintubation really did not vary much, but the ICU, the mortality or the length of stay was pretty much similar. So HFNC was not deemed inferior to NIV in patients requiring in hypoxemic patients after cardiothoracic surgery. So if you have any cardiothoracic surgery patient who is not compliant with NIV, you can very well use HFNC to support the hypoxemia. Now, effect of post-extubation hypoxemia, where they used HFNC versus non-invasive ventilation on reintubation in high-risk patients. The high flow nasal oxygen, again in this study as well, it was concluded that it is not inferior to NIV for preventing reintubation and post-extubation respiratory failure. Now, a continuation study was done by the same author in 2023. Now, they have used humidified NIV in comparison to HFNC, and they have proven that humidified NIV has better outcomes as compared to HFNC to prevent reintubation in high-risk patients. So whenever you have, whether you want to use the non-invasive modes of ventilation for rescue, or you want to wean your patient from mechanical ventilation, so the picture goes this way. You go with your conventional oxygen therapy, patient is not responding to it, you escalate it to high flow nasal oxygen, then your CPAP or your NIV, and again the weaning goes in the opposite direction. You can start with your NIV, gradually come down to HFNC, and then to your conventional oxygen therapy. I know there are a lot of other components with regards to BiPAP and everything. The circuits, the knobology, that is there that I have not discussed in this PowerPoint. I think it is easier and better understandable when you do it hands-on tomorrow in the workshop. And if there are any questions, I'm happy to take them.
Thank you, Dr. Pragna. So very nicely elaborated about the different types of non-invasive way of positive pressure ventilation, and how we can choose our interface. That is very important, because on that depends the patient compliance a lot. And because one of the most limiting factor for NIV is the patient compliance because of the interface, and how we need to monitor when we are using NIV on any patient. And very nicely said about the mentioned the Florali trial also, where the newly yeah, where we have started HFNC on a wide wide numbers. So anyone having any doubt? I think we are done for the day, sir.
Yes, we'll meet tomorrow. So good night, all of you, and we'll meet tomorrow at 2:30 RF8, first floor of conference room, the Kapol Nivas building. So see you there. Bye.